Okay, so let's pick up where we left off from Thursday lecture. The last thing we were covering was spinal cord injuries and where the injury is impeded within the spinal cord column will kind of provide us some information on the lost function and ability that they might have. So if we look over here to our grid, we can see, paraplegic. The further up you go up the spine, the further they have limitations within their body. The further down the spine, the more ability that they have. So, if we look at Tony, he's a paraplegic, so his injury is lower in the thoracic area compared to Mikey, or where he may be, more in the high thoracic area, C level, cervical level, with being more quadriplegic. So this tells us a lot of information. So one of the real important things to know is to find out where within the spinal cord are they impacted, and so that we can get some understanding about what function and what loss they may have. The other thing that is really important to find out is if it's a complete or incomplete injury. Complete meaning, let's say they had a thoracic 7 injury. Complete would be that it would sever the entire spinal nerve. So from that portion down, they would have function, but from that portion or that portion up to the brain, they would have function. From that portion down, there would be absolutely no function. If it's incomplete, there may be some kind of fibers of that spinal cord that is still firing, and so they may have some feeling on different body parts lower. So you can just kind of find out more if you know where the area of the spine is injured, and then whether it's complete or incomplete. So hopefully during the Q&A with our guest speakers, they talked about some of them having feeling, in their feet or bladder. Some didn't, some did. It really just depends whether or not those specific nerves within the spinal cord were damaged or not. And so those are important information that you should know. So the last slide that we ended before we got to talking to the guest speakers was just how to handle potential spine injuries. The biggest thing is that if there's at all a sign of any spinal cord injury, we don't want to move them at all. We want to try to mobilize, their neck and spine as much as possible. They may have pressure in their head or neck. They might have back pain. They might be feeling some paralysis, lack of coordination or weakness in any part of the body. They might lose some sensation, some numbness or tingling within their hands or feet. So they may even have impaired breathing because of it. So one of the most important things to do is, if at all you suspect someone having a neck spinal cord injury, is just call 911 and try to keep the victim warm from not going in shock, and immobilize them as much as possible. So what are the kind of treatment phases that individuals with spinal cord injuries go through? And so this is meaning more so not individuals that are born with it, but ones that acquire it within their life. So the first phase is really hospitalization. So that's the acute medical treatment. Really what they're trying to do is get them stable as far as being able to breathe on their own, to get their heart rate, their blood pressure to be as normal as possible. So really just making sure that they are in a best of kind of homeostasis that they can be in based upon the trauma that their body experienced. Next, they go into rehabilitation. So one of the biggest things is just the adjustment to the injury. That's a lot more into the mental and affective domain, is just making sure that, they're getting therapy and they're talking about it and they're dealing with their injury correctly. And, sometimes it's difficult because the doctors will say you'll never walk again, you'll never do this again, you'll never do that again. It's very difficult to know really what their ability is within this acute medical treatment phase and even in the beginning of the rehabilitation phase because so much of the body is swollen and just impacted from that trauma that time really can bring back some additional function that a doctor might thought they would never have. And then really just starting on basic living skills. How are they transferring themselves into the wheelchair, out of the wheelchair, and just how are they going to dress themselves? How are they going to urinate, bowels, all of that. Then the next phase is really return to home and school. So how do we transition them back to, new normal routine? And some secondary issues that come with, leaving the hospital and rehab and coming back into, the world of which they know is for sure the psychological acceptance of their injury and what their life now looks like, and dealing with that. There's also additional health conditions they need to be aware of. So pressure sores or decubitus, thank you, decubitus ulcers. Sorry about that. So pressure sores within the skin that you need to be aware of. Some bruising or fractures because of the fact that they may not be able to feel those parts of the body. Urinary tract infections are possible. They might have some spasticity going on, some contractures as far as tightening of their ligaments and tendons, and obesity as well if they're not moving as much as they were before but are still eating the same amount. So when it comes to physical education, sport, rehab, what are some things that we need to focus on? One is just trying to realize that we want positive focused improvement of their body image now that it might be different from what it was before. So we need to acknowledge that and kind of work on, the affective domain within that. As far as physical, we're definitely looking at increasing upper body strength, range of motion, flexibility with their arms, endurance as well. And then, whatever, if they're using crutches, a walker, or a wheelchair, just trying to increase their confidence within those skills. Next thing is really just making sure that we're open and communicating and letting them vent and talk about this acceptance of their disability and the wheelchair or walker crutches that they may have to be using. And many of the positives come from when we implement and introduce them to recreation, sport skills, wheelchair sports, and ways to, still be physically active and social through sports, which we heard lots of our guest speakers talk about the impact of physical activity and sport having on their lives. We also might need to realize that they need pressure releases. So many times they might need to kind of reposition themselves in their wheelchair. Some that are newly injured that may be in a power wheelchair might have to recline the chair and kind of go into more of a laying position to relieve some pressure areas within their body. We should be doing stretching both pre and post any physical education or movement to help decrease spasticity. And if they are using external catheters, they should be emptied prior to physical activity. So just being aware of that. So fitness and spinal cord injuries. Well, obesity is a potential issue that we need to be aware of. So movement is very, very important for these individuals. We also already talked about emphasizing flexibility, strength, endurance. We may have to deal with some muscle imbalances. Some of them may have an arm that's firing way more than the other arm. And so how to work kind of both those arms individually, but at the same time increasing the strength and flexibility of both those arms as much as possible. We do have to be aware of hypotension, which is low blood pressure that may occur from the blood pooling into their lower legs. Also, thermoregulation can be an issue. So as you can see here, I have a spray bottle. This is when I was coaching the quad rugby team, and many of the athletes in the quad rugby team, their injury within their spine was above their ability to thermoregulate. And how do we thermoregulate? So we do that through sweating, right? to cool our body off. And then if we're really cold, we do that through shivering. So some individuals with spinal cord injure is higher than where thermoregulation is within the spinal cord, and so their body does not thermoregulate. So um, here, spraying a bottle of water to pretty much implement that sweating, so to be able to cool them down because their body just is not going to sweat. It just doesn't know to do that anymore because the spinal cord is injured in that area. Autonomic dysreflexia is also present. So that could be, just a very quick, rapid increase in heart rate and blood pressure, usually getting about 120 beats per minute that we need to be aware of. And this many times can be due to an infection within the body, a fracture that might have occurred, but pretty much for individuals with spinal cord injury is telling them very quickly that something is not correct. Something is not going right within their body. And so it's really important to acknowledge that and usually take them into the ER, urgent care, to figure out what's going on. So one way we can measure fitness for individuals with spinal cord injuries is through the Brockport Physical Fitness Test, which actually has fitness test items specific for individuals in wheelchairs. So next one that I want to cover that's within is polio. Polio we don't see as much. It would be more so if you're going into rehabilitation. Usually right now it's impacted those that are older in their 50s and 60s just because of the polio epidemic. However, we are seeing an increase in polio because of families choosing not to vaccinate their children. So there are some more cases of polio coming back. So what is poliomyelitis? Myelitis is paralysis that's caused by a viral infection that impacts the motor cells within the spinal cord. And the severity and degree really just depends on how many of those motor cells have been affected by the infection and what's the location of it. So many times those that get polio will have a very, very high fever, and the paralysis that occurs could be temporary or could be permanent. So the Salk vaccine is the one that many of us have received when we're a newborn, which decreases the occurrence of the polio viral infection. But we do need to be aware of it and that we may end up teaching or instructing someone with it. So some post-polio syndrome that we need to be aware of is that we should be aware of overusing the remaining muscle fibers that are there. So again, swimming, number one activity to be doing with this population, because when we overuse these muscle fibers and they already have a lower number of these muscle fibers because of the impact the infection had on the motor cells, it can cause additional muscle and joint pain, increase their fatigue, and then also cause them to lose strength. So we really need to be aware of that we're not overusing beyond developing what muscle fibers they do have. Another area that may cause spinal cord disability or injury is spina bifida. So spina bifida is a congenital birth defect that occurs usually in your utero, so as the baby is developing. And usually what this is a cause of the neural tube, which is your spinal cord, that it doesn't fully close with development. And so typically you will see that the spinal cord is infused within the spinal column, and it is pretty much covered by our spine to protect it from injury. Well, there are 3 different classifications of spina bifida, and this is where the spinal cord is just not being as protected as needed. So something within the development of the fetus has gone wrong. Occulta is the mildest form of spina bifida, and it is actually the least common. And so here, the last bone of the vertebrae, this is usually happens within the lumbar area, doesn't fully develop, and you'll see usually a dark patch of hair, and the body's producing this hair to provide just additional support to the spinal cord. And so, limited impact with lower body. Usually, they do a surgery to try to protect the spinal cord, but some paralysis and impact of the lower limbs. Next is meningocele, and this is where there is an outcase of kind of spinal fluid within the lumbar area. However, the spinal cord is still intact and still within the area that it should be. However, myeliomeningocele is the most severe type of spina bifida, but it's also the most common. And here you can see is that there's a outward section of just skin that's covering really the spinal cord. And so the spinal cord is very kind of visible to the outside world, to where a bump or a hit within that could be severely painful. And so this level of spina bifida usually causes pretty significant paralysis to those fibers that are being impacted, and usually causes some sort of paralysis to the lower limbs. And with this usually is a lot of surgeries, tethering of the spinal cord. So they pull the spinal cord down and tie it, really to try to keep it from continuing to go outside of the body and stay protected by the spine. And so surgeries will occur, and you'll see kind of their lower back, just a lot of different surgeries trying to protect the spinal cord. So many of you know Aaron Wheels Fotheringham. He actually was born with spina bifida, and so he does have the capability of walking using crutches, but chooses for the most part to use a wheelchair. And so, again, was born with spina bifida, and there's not really a cause for a cure for it, but with surgeries they can deviate as much as the impact as they possibly can. So some things to be aware of is that screening now occurs for spina bifida, and at times they'll do prenatal surgery to help decrease the impact of injury to the spinal cord. Some individuals with spina bifida will have hydrocephalus, meaning water within their head and brain. So a shunt may be put in to decrease the pressure and the water from within the head. So, we need to be aware of some contraindications when it comes to individuals that may have shunts in their head. The other one I talked briefly about is tethering of the spinal cord. So with the growth of the spinal cord, it may stretch and cause a loss of muscular strength, reduce their gait or walking pattern, and cause further loss of bladder and bowel function. And so, many of them, usually about twice within their early adulthood, will have to get tethering of their spinal cord, where they pull it tighter and kind of stretch it. And so I've heard from individuals I know with spina bifida is that it's very painful, the pain that they receive on their spinal cord, and then usually during the tethering as well. So what are some physical education, sport, rehab things to be aware of when we are working with individuals with spina bifida or with polio? One, we have to be aware of their assistive devices that they may be using. So crutches, a walker, braces that they might be wearing, such as this little man over here. He has some AFOs that he wears. So be aware of them, work with the physical therapist with them. We're always trying to maintain that range of motion, flexibility, promote walking as much as possible, and some weight-bearing activities is really beneficial just to increase the bone strength and circulation. So getting them up in their standard, getting them up and walking if possible, as much as possible is really good. Another thing, be aware of obesity. Some bone deformations may occur, some fractures, postural deviations, pressure sores, bruising, UTI, very similar to those of spinal cord injuries as well. Another thing that you really, really, really need to be aware of is Individuals with spina bifida may be allergic to latex. So if they are, then we need to make sure that we have non-latex gloves, and we are also using equipment that does not have latex in it. But for the most part, we really just want to develop their motor skills and fitness and strength, just like we would to any other student through physical education sport. So the last area we want to cover is spinal column deviations. So that's scoliosis, kyphosis, lordosis, spondylosis, and spondyliosis. So here we have a picture of someone with a normal spine. Usually it's a little bit of an S shape that we need to see. So lordosis is a hyperextensive of degree of the lower part of the spinal cord. Kyphosis, or kind of like that humpback, would be a extreme curve within the upper area of the spinal cord or spinal column. Scoliosis is to the side, either to the left or to the right, which many of us do scoliosis screenings within the schools. The last two, which usually aren't very common, is spondyliosis and spindylosis. And so what this is actually a break within the vertebrae, which can cause some sublux of the last lumbar vertebra. So the spondylosis is just a fracture within the lumbar spine, and then spondylolisthesis is a full break, causing right here forward slippage of the vertebrae and very kind of significant pain within the pelvic kind of lower lumbar area. So what are some classifications of spinal cord or spinal column deviations? It would be one structural and the other one non-structural. So structural means that is their actual permanent vertebrae are structurally deformed. So that is an orthopedic impairment, and usually it is permanent. Non-structural means that the deviation can be realigned with exercise, stretching, practice to kind of increase the posture. So sometimes they'll do some bracing for those with structural classification, since there's no way to really increase the correctiveness of their deviation. They might support the body through some bracing until they're able to do some sort of surgery to help kind of fix the deviation as much as possible. So what are some causes? Really, it's idiopathic, meaning that the cause is unknown. For many structural classifications, they're not sure why it happens, but something within development must go wrong for that to occur. As far as non-structural classification, usually the cause of that is neuromuscular. So meaning that nerves within the muscles aren't firing to support the vertebra, or there might be some muscular imbalance or flexibility imbalance causing the spinal column deviation to occur. So one of the biggest, most important things is just postural screening. Thankfully, we are doing them within the education system, looking at scoliosis and trying to early identify any of those spinal deviations. So again, scoliosis could be an S-shape part of the spinal column. So usually the major curve and then a secondary or compensatory minor curve to one side and then towards the other side to kind of compensate for that. Females tend to be 5 times more likely to become more severe if not treated from scoliosis. There are C-shaped curves where they don't have this secondary compensation curve, where it's literally just one side of scoliosis. So the spine just makes a C compared to this S shape. Usually individuals with a C-shaped scoliosis curve will have balance difficulties, have issues with seating, and we have to be aware of additional pressure on their internal organs. So treatment really depends on whether it's non-structural or structural. So structural, meaning that the bones themselves are deformed, then most of the time bracing is the best for that. As far as non-structural, again, we're going to be looking at increase in the muscular strength, and just really doing exercises and flexibility to help enhance that scoliosis. So here's a book all on scoliosis, exercise for prevention and also correction of it. So we want to make sure that we work on both strength and flexibility, making routines fun and motivating, always provide warm up and cool down to try to get the muscles to be as flexible as possible. It's really important to do static over dynamic stretching for this group of population, just to make sure that we're not pushing the flexibility too significant, that we're causing damage to the bones. And individuals with scoliosis should be integrated into regular physical education. And we need to make sure that anytime we are doing exercises that we really promote correct form and making sure that they're doing the exercises slowly and correctly. Using a mirror so they can watch themselves perform the exercise in the mirror is very beneficial to also improve increase in form. And we really need to emphasize symmetrical exercises, meaning that working both sides of the bodies, not just the one side that might be impacted or might need to be enhanced as far as strength and flexibility. And also, we need to be aware of limitations that may be imposed if they are wearing their brace. The last area is orthopedic devices that may be worn with individuals with spinal cord injuries or different disabilities. So these could be splints or braces that kind of increase the functionability due to some neuromuscular limitations. So you can see this little man over here they go up to his thigh braces that he can lock in to be straight, or you can unlock to be able to bend. So AFOs are ankle foot orthotic. KFOs or KFOs are knee, ankle, foot orthotics. HK AFOs are hip, knee, ankle, foot orthotic. So all the way go up to the hip. So right now for this picture, he's wearing a KFO. So it's a knee, ankle, foot orthotic. So it's supporting the knee, the ankle, and then also the foot. And then hip ones will go all the way up to their waist. And they may be, again, using some sort of cane, a walker, or crutches to support their mobility. So overall, when we are looking at physical education and physical activity, the best thing is to try to include them as much as possible. We want to focus on their abilities and make sure that we are increasing their strength and flexibility. We may need to substitute some objectives for locomotor skills. Instead of jumping in their wheelchair, we might have them try to do a wheelie, or just be creative and be fun with different ways that we can enhance their ability to control their assisted device and also their motor skills. As always, we should make decisions based off of assessment, and we are going to have to make some accommodations and modifications to ensure success and learning. And the best thing for these individuals is to teach self-advocacy. Just like our guest speakers, we need them to have a voice and be able to speak up for themselves.